I am in just a moment going to turn this over to Elizabeth Paul. Before I have Elizabeth talk, I just want to mention that in the past several years, we have really strived to have a patient voice to hear from the patients that we serve. We've done this for many years now. As I said, this is the 11th annual obesity forum, probably for the past 5 years or so. We've always had a patient advocate, and we find that it's so important. We work with patients every day, but we rarely sit down and have a conversation with them about their struggle or their perception of living with obesity, and that's how we're going to start today. Elizabeth, I'm going to turn it over to you.
Thank you, Dr. Kushner. I am delighted to be here today and to be able to share a little bit about my own story living with obesity and the patient perspective. So as Dr. Kushner said, I am Elizabeth Paul. I work in nonprofits as the Director of Development for Connections Ministry, a homeless ministry here in Mankato, Minnesota. But more importantly, I am a patient advocate and board member for the Obesity Action Coalition, which I'll talk about a little bit. There are my financial disclosures that I have had opportunities to do as a patient advocate, and some objectives for my talk today. In particular, we'll be talking about some of the realities about living with obesity and the dangers of weight bias and stigma, particularly in the healthcare setting. So I have lived with obesity my whole life. I grew up in a family with my parents and my sister, and despite eating the same things, despite having a very active childhood, I was the one person in my family who struggled with weight. I ate the same foods, I played soccer, I walked to and from school every day, and was always overweight. I was put on my first diet that I was aware of in 6th grade. And I always like to say that I was aware of, because I know that my mother was working hard to address my weight before that. But that was in 6th grade was the first time that I went on a program of my own at her request. And that really began a lifetime of dieting and being on and off weight management programming and attempting to manage my weight, usually on my own. Because, even back in the day, weight management programming was very much here's what you need to do to fix your problem. And it was really perceived as my problem for me to fix, because it was something that I had done. And through all of that, I gained and lost weight all through my adolescent, my teen years, my early childhood, and into my marriage and having my first kid. After I had my son there, I actually began blogging, and I started a weight loss blog, and I said, this is going to be my time to get it done, and I'm going to fix it forever. And I'm sure you, if you've ever worked with patients living with obesity, you have heard that before. And I lost 80 to 100 pounds, and did so in a very public way. And losing weight in a public setting can be a real traumatizing experience, because you open yourself up to all sorts of people who express that you're doing something this way or that way or wrong. You open yourself up to bias and trolls and all sorts of stigma that was already playing out in my head. And it really exacerbated the feeling that I was somehow inadequate in dealing with my weight. And when I was successful, things felt good. When I was unsuccessful, things felt really bad. And of course, for me, the history of being successful only went so far because I ran smack into my disease after a little bit and the weight began to come back on. The unfortunate reality of obesity is it becomes a solo journey, but a very public roller coaster. When we lose weight, we are seen by those around us and celebrated. We're complimented, we're cheered on, and we're asked what we're doing, what's going so well. We're complimented for how much weight we've lost, how good we look. But the reality also is true. When we gain weight, it's also visible. And the shame that comes with this, both in what people say and don't say, but also in the internalized shame that we also experience, becomes very real and damaging for both our mental and our physical health. Beyond that, the world just isn't built for people who live in larger bodies. I am always aware of being a larger person, a person living with obesity, and that can be going out to a restaurant or a movie theater. It can be going to the doctor's office. Are there chairs that suit me? Will there be room on a plane? Will someone say something to me? I can be out exercising and people will jeer at me from a car. It can be exhausting anticipating whether or not there will be something said or space enough for me in the world. The reality of weight bias is it causes people to comment in both well-intentioned, I'm concerned about your health, or I want, as a parent might say, or a loved one might say, or in purposefully cruel ways as well. But the reality is, obesity is a disease, but we still view it as a function of our willpower or our laziness. Now, I know enough about myself to know that I am neither lazy nor do I lack willpower. I work 40 hours a week. I have 2 kids. I volunteer in a whole host of ways. I am an active, engaged member of society. I am not a lazy person. So why do I internalize that when it comes to my weight? The reality is we get all of these messages from a whole host of people, including from our history in the healthcare setting. So as I am presenting to you today, my big question for you, as you have people living with obesity who stand or sit in front of you in your doctor's offices, in your clinics, no matter where you are seeing patients, my question is, what experience are you going to provide them? Because the reality is everyone who lives with obesity experiences some level of weight bias, stigma, discrimination, or trauma. And that often happens at the hands of medical providers. And it often becomes internalized. But the reality is if a patient has taken the time to make a doctor's appointment and is sitting in front of you, they're willing to take on the risk of experiencing bias again for the sake of their health. If a patient didn't care about their health, they would not be sitting at the doctor's office. So what are you going to provide? What experience? So I have some keys that I think of are the necessities for bias-free care for people living with obesity. And in reality, these are keys for bias-free care in any situation, but in particular for people living with obesity. And we'll talk a little bit about all three. Active listening, allying with your patients and for your patients, and access to treatment. So active listening. This should be no surprise to anyone who is trained in the medical field that listening is important and you want to understand where your patient is coming from, but it's even more critical for people who live with obesity. I won't tell you all of the stories that I have from healthcare settings, but I'm going to start with one that I think is fairly telling. I once went in to urgent care with an ear infection. And an ear infection is a pretty common ailment. You look in your ear, you see if you need antibiotics or not, see if anything else is going on. And instead, I ended up with a 20-minute lecture from the urgent care doctor about my weight. And has anyone ever talked to me about my weight and what I should do about it? Now, at that time, I was 30 something, and I can guarantee you, I knew I struggled with obesity, and I was well aware of it, the fact. And the urgent care doctor had no prior history with me, had no knowledge of whether I had gained or lost weight in my recent history, but still felt the need to lecture me when all I really needed was to know whether I needed antibiotics to treat my ear infection. So with active listening, we have to take the first things first. Attend to the reason a patient made an appointment. We won't trust you to treat our obesity if we can't trust you to treat the reason we came in the first place. And that might be knee pain. It might be concern about fertility or digestive issue. It may be headaches. It may be something related to weight or unrelated to weight. But if you don't listen to why we are there and jump right to our weight, we won't listen. Listen to understand what's going on. Don't listen to convince us of something that you have planned for us. And another key thing to remember is that every person is in a different place on their obesity journey. Unfortunately, because of a history of bias and stigma, not all people are ready to face treatment or ready to deal with any sort of weight management. And you aren't going to get people there by shaming or blaming them. If you can't build a trusting relationship with someone apart from their obesity, they won't get to the point where they can treat their obesity in a safe environment. It's also really important to ally with your patients. And what does that mean in a clinical setting? So it means helping the entire space to be bias-free. It means speaking up to colleagues when you hear bias in the setting. And that can be jokes. It can mean side comments among your staff about patients behind their back. It can be as simple as being sincere in your desire to collaborate or celebrating them with a patient when they meet their health goals. But it can also be looking around your facility and ensuring that the facility itself is well equipped for people living with obesity. Do you have spaces in waiting rooms and exam rooms that are suitable for people of all sizes? Waiting rooms are getting a whole lot better about having 1 or 2 chairs that are larger. But in 9 times out of 10, I go into an exam room and they still have chairs with the exact same arms. So if I am allowed to be comfortable in the waiting room, but then I have to be uncomfortable in the exam room, does that say we are open and allying with our patients? Do you make people take their weight at every appointment? Is it necessary to take their weight at every appointment? Do you make them do it out in the hallway where everyone else can see? Do you have a blood pressure cuff that fits everyone in every room? Or does the nurse have to call down the hall or walk down the hall in a huffy way and say, I have to go get the large cuff, which has happened way more than I'd like to admit? Do you have gowns that fit everybody? Think about the little things, the microaggressions that may indicate whether or not your space is a safe one for people of all sizes. And finally, think about access to care and access to treatment. And this is where shared decision-making really becomes crucial. The reality is one size does not fit all for patients. We can't ignore side effects, we can't ignore cost, and we can't ignore patients' concern when it comes to treatments. Several years ago, more than a decade ago at this point, I was on an anti-obesity med that gave me insomnia. At the time, I had a 4-year-old, and it was a really unsustainable side effect for me. I was working full time and I had a young child. I couldn't really manage not sleeping. And unfortunately, the doctor who was in weight management, this was an obesity doctor at the time, said, well, but at least you're losing weight. Isn't it worth it? And for me at the time, it wasn't worth it. It was unsustainable. We have to listen to the realities of our patients' lives and acknowledge that if something isn't sustainable, then the treatment isn't going to work. With the realities of anti-obesity meds, surgery, and all of the treatments now, we also have to recognize that cost is a major factor. And so there are some ideas for looking around costs that are on the next slide. In addition, we also have to take in a patient's concern. Do they have a fear of needles? Do they have other issues that may make them not a good candidate for surgery, or other ideas around there? Reality is, when it comes to treatment for obesity, insurance often is more of a barrier than providing access to care. So sometimes it requires doctors to be creative. So consider prescribing for comorbidities, for prediabetes, for diabetes if it's appropriate in your case, for insulin resistance. Look at the ways that we can make treatments available to people outside of what their insurance restrictions are. Know what clinical trials are going on in their area. It's a good opportunity to see if there are new ways for a patient to have an opportunity to try something they might not otherwise have an opportunity to try, and identify what cost-saving programs are for some of the anti-obesity medications that are out there. Knowing some of these things help you present something to your patient that can really be an asset, not just a carrot that they can't access. And finally, as I come to a close on my time, I want to remind you, I trust, even in all of my experiences with bias in the healthcare field and in my own life, that people, that doctors want the best for people living with obesity. But we have to approach things in as bias-free way as possible. They're your patient, but it's our lives. And so help us to make the best decision we can where we're at right now. Thank you so much.